anemia is due to defective red blood cells or hemoglobin. Now, all of these are genetic. All of these will also have hemolysis going on. Hemolysis, hemo meaning blood, lysis meaning breaking up. And what happens here is that you get a breakdown of red blood cells prematurely. They're supposed to break down at 120 days, not at 70 days. Okay, so they start breaking down a lot earlier. And these are the ones that we're going to be talking about. Okay, so we have spherocytosis, glucose-6-phosphate dehydrogenase, or G6PD deficiency, sickle cell anemia, and thalassemia. Okay, so there's something that's being defective in the hemoglobin or red blood cells. Okay, so let me just talk briefly about what hemolysis is, and then we'll talk about these diseases. So hemolysis, again, is premature destruction of the red blood cells. Less than 120 days, these are being destroyed. Okay? Features is that you'll get anemia, obviously. And because you're destroying the red blood cells, the bone marrow is going to get hyperactive. It wants to start making a lot of red blood cells. So the factories are really burning. And because of this, it will make your bones become more painful. Because there's so much. So bone pain means that there's going to be something happening with the bone, whether it's leukemia, because there's a lot of cells being produced. It could be because of red blood cells are being made. All right, but I don't want you to think that Dr. Brown says that bone pain means cancer. It's not what I meant. It's just that's a sign of it. But you could have somebody who is 12 years old and has bone pain, but that's because they're going through puberty and they're growing at such a fast rate. That could be enough to say that that's causing bone pain. Okay. So I don't want you to think that that means bad all the time. You're going to have an increase of erythropoietin, right? Makes sense? And reticulocyte count is also going to increase because you're making more red blood cells. Okay? The symptoms, well, depends on etiology. All right? You could get an enlarged spleen. You could have jaundice. You could have, since the red blood cells are being broken up, you're going to have pieces of hemoglobin that are going to be in the bloodstream a lot longer. We call that hemoglobinemia. And because there's so much of it, some of it will actually go through the kidneys and it'll spill out in your urine too. In that case, we call it hemoglobinuria. Okay? How would this appear? As dark urine. All right? You have the hemoglobin there, the redness. So that becomes very dark. It appears dark in there. Okay? All right, so let's talk about spherocytosis. Okay? Spherocytosis is due to the fact that these people, and these are all genetic diseases, okay? So it's not something you can just get by someone coughing on you, right? You have in your red blood cells a protein called spectrin. Spectrin is actually is made in here to create this biconcavity shape. And it also gives it some of the flexibility. Because these little red blood cells have to squeeze through those small capillaries. So it needs to bend a little bit to do that. The spectrum is allowing the red blood cells to do that. If there is no spectrum, then these cells actually become more of a sphere, a ball, as the name implies. They blow up like a balloon. They don't blow up, but they become more like a ball. Now, these will get clogged in all your bloodstreams because they can't get through those narrow passages. It's not flexible. And that's what's happening with that. So they become very rigid spheres, and they have problems squeezing through those little capillaries. Okay? They'll start breaking down, causing hemolysis. And the treatment for this is really just supportive. Splenectomy kind of improves things because the spleen actually is going to get clogged with all this. We remove the spleen so it won't get so clogged. The problem is that there's no cure for it. It's just going to improve it a little bit, but they don't live that long. So.
What if removing your spleen that cause other complications?
Yeah, well, right. It's exactly right. So removing the spleen, they're going to be on a daily dose of penicillin for the rest of their lives because basically the spleen is just an enlarged tonsil. So it is it's like an enlarged lymph node. But people live without a spleen for a long time. But the thing is, yeah, you're going to be decreasing your immune system, so they have to have other precautions. They get the pneumo vaccine, they get other things to try and decrease any risk for certain infections. So you're right, yeah. Okay? Any questions about spherocytosis? That's what it looks like. They look like little balls over here, right? Okay. Then we have this, glucose 6-phosphate dehydrogenase, or G6PD deficiency. Okay? This is an X-linked recessive disease. So what does that mean, right? We talked about this before. Who gets this? Mostly males. Let me just explain to you again, just as a reiteration. If a female is XX, she gets this X from mom and this X from dad, but this has a disease on it, G6PD deficiency, but there's another X here that's quite fine, so this one actually predominates, so it's fine. But in a person who's XY, like a male, then this X, if that's going to be diseased, or let's say that has the deficiency on it, now that's the only X the male has, so he's going to have the disease. So women are usually carriers, but males have the disease. Women can have the disease, but they got to get it from mom and dad, which is a very rare thing for that to happen. Okay, but it can happen. All right, we clear with understanding that? All right, 10% of black men have this. Okay, it's due to no G6PD in the red blood cells. This is needed to protect the red blood cells from dealing with oxidative stress. Okay? So red blood cells, if they have oxidation going on, and that's where the free radicals come in, right? You learned about that in AP 1 or 2, right? What happens here is the red blood cells get fragile and they start getting destroyed. They hemolyze, okay? You're hemolyzed. There's certain substances that will exacerbate this. For instance, certain oxidizing medication, aspirin, will do this. Toxins, certain infections, foods. A big one is these fava beans. Have you heard about fava beans? Right? I never had fava beans. The only time I saw fava beans is in Silence of the Lambs, where he said, like, I ate his liver with a fine Chianti and a plate of fava beans. Right? I never had it. But if you ever see something like an NCLEX exam or some other exam and you see the word fava beans, think of G6PD. It's kind of like, I know where they're going with fava beans. All right? There's no other place that I would see something like this. These little pearls will help you. Okay? The only thing you can do is just supportive on this and avoid some of these other stimulants that would cause that. Okay? And what they, yeah, and that's what happens. Now, sickle cell anemia, this is big. Okay? Sickle cell anemia, 10% of African Americans have this. They're carrier, but only 0.3% actually have the disease. Now, what does that mean, 0.3%? 1 in 300, okay, have the disease. What happens here is that the hemoglobin molecule has, the whole hemoglobin molecule has about 600 to 700 amino acids on it. Actually, I think it's 600. 600 amino acids. That's a lot of amino acids. So what made this whole thing happen? Well, one of the amino acids, glutamate acid, or glutamate, I think that's what it is, gets replaced with valine. Just that one substitution, that's it, causes these red blood cells to turn into a sickle. That 1 point mutation out of 600 changes this whole thing, okay? And what happens here is that the red blood cells become very sickle. I'll show you that in a moment. And problem is that oxygen is, it's difficult for oxygen to bind to that. And these sickles get easily clogged in the capillaries. And what happens is if it gets occluded in that area, that capillary, that blood vessel gets occluded, there's going to be stopped, like a motor vehicle accident happens on a highway, then no blood can actually get beyond that point, and the area that that place was supposed to go to has no oxygen and starts dying down, and it starts causing a lot of pain. Pain is a good thing. Pain gets you to the hospital. You have a heart attack over here, you got pain in your chest, it's going to get you to the hospital. All right? If you have a silent MI, like many diabetics have, they're not going to feel this, they're not going to get to the hospital. Pain is a good thing. All right? Does that make sense? It tells you, alerts you that something's going on here. Okay? So that's what they kind of look like. These are what the normal red blood cells go here, and here's what sickle cell. Now, people who have sickle cell trait, the carriers, okay, they actually could live to a ripe old age of 120. They're fine. The people who have the disease, unfortunately, 50% of them only make it to 40 years old. Okay? They usually die of infections. Yeah, okay. So that's what's happening with that. So what's happening here is that this is what your normal red blood cells should look like, and this is what your hemoglobin should look like, big and poofy. In people with sickle cell anemia, their cells over here kind of look sickle. The hemoglobin is kind of squished. It's hard to get oxygen in there. That's what happens with that. Okay? Remember doing these Punnett squares? So if mom has sickle cell trait and dad has sickle cell disease, what's the chances that their offspring is going to have just the trait? Which ones are going to have normal, right? So hint, hint, you should be able to do this. Stuff we learned from AMP1, you're now applying into here. Again, it's about nursing patient education, okay? What's my, the nurse or the patient could say to you, well, I have sickle cell trait and my husband has sickle cell trait. What's the chances of me getting it? You don't have to refer that patient to the doctor. You can answer that question. And what's the chances of you actually, if you have the trait and mom has the trait and dad has the trait, what's the chances that the baby's going to have the full-fledged disease? 25%. Right, you could say that. That's knowledge. You're teaching the patient education, okay? All right, some complications that happen with sickle cell anemia, okay? Anemia itself, that's pretty straightforward, right? The red blood cells, they start breaking down. Hemolysis, okay, what's left there. Obstructions to small blood vessels. You could have ischemia. If it starts clogging up those blood vessels, then the area beyond that is not going to get oxygen. It's going to get ischemic and eventually it's going to infarct, die, and turn to necrosis, all right? If it goes in the veins, yes, it can start thrombosis. And it could throw a thrombosis. It could actually go into your lungs. You're going to have hyperactivity of the bone marrow in children. So the bone marrow is trying to compensate. It's not making a lot of, remember, if you have low oxygen in the blood, which is happening in sickle cell anemia, that's going to go to your bone marrow, the kidneys to secrete erythropoietin. The erythropoietin is then going to go to your bone marrow to make more red blood cells, right? So now it's always going to happen, and now your bone marrow is going to get very hyperactive. And it gets so much that as these kids' bones are starting to grow, because they have to grow with it, they start growing, but inside the bone marrow is getting wider and wider because it's being very productive in making red blood cells, whether good or bad ones. So now the bone is not being able to form properly because it's being pressed from the inside out. So they get a lot of bone deformities. And they get a lot of infections. Eventually, that spleen is going to get so clogged up with all these sickle cell red blood cells that the spleen function is going to decrease, and we call it hyposplenism. So the spleen starts getting destroyed. It won't work anymore. And that's, like she was mentioning, that's what's going to lead to more infections. Okay? Ideally, the osteomyelitis, if you see someone with salmonella osteomyelitis, think sickle cell. Okay? Also, if they have sepsis, it's usually pneumococcal, and the most common cause of death is, like I said, infections. Okay? So this I took from your book, all the different complications. I mentioned a few of them already, but you could look at this and it would make sense. I'm not here, you don't need to memorize this stuff. Just think of what's happening, and you could come up with different things that's happening. It just makes sense. So treatment is supportive. occasional transfusions. You don't want to do too many transfusions on here because their body's still making sickle cells. And like I said, they're going to be on prophylactic daily penicillin because they're at risk of having a lot of infections. Look at the pneumo vaccine and so forth. Okay? Prognosis is poor if you have the disease. Like I said, about 50% live to only 40 years old. Infections is the most common cause of disease, or death, rather. And if you have just the carrier, like I said, you could live to a ripe old age of 120 if your body can withstand that. All right? So if you're a carrier, you're fine. Okay? You just have to worry about, if your husband or wife has sickle cell anemia, then you got to be concerned about what's the chances that your child will have it too. Okay? Questions on that? All right, thalassemia. Thalassemia is basically a problem with making the change in the hemoglobin. Now, more commonly, you're going to see people from the Mediterranean and the Southeast Asian origin that actually have this. So we have go back to our picture. A hemoglobin molecule is made up of 4 chains, right? They're made up of a beta chain over here. We'll say beta 1. Another beta chain over here, a different kind, and we call that beta 2. We also have another chain over here, we'll call that alpha 1, and another chain over here, we'll call that alpha 2. Okay? And in the center of each one of these, you have a heme. And that's going to hold an oxygen molecule. This whole thing is hemoglobin. And it's made up of 4 chains. Okay? Now, in adult hemoglobin, we have 2 beta chains and 2 alpha chains. And this works perfectly. You want oxygen to come off and be able to come on quite reversibly. In fetuses, their fetal hemoglobin is different. What they have is 4 alpha chains. And what that does is it makes the oxygen bind onto the hemoglobin much stronger, with a higher affinity, a stronger attraction to it. You would expect that and want that in the fetus so that it could pass through the placenta and be hooked on. You don't want it to just, as it passes through, to come off. So you want it to stay on it. So what's happening here with thalassemias is that in an adult, what happens here is that one of these chains is not made properly. And that's not going to be good. So your body will make one of the other proteins. So in other words, if it's supposed to be 2 alpha and 2 beta, so your body compensates and says, well, you're missing, and there's different types of thalassemias. It's missing beta 2, so we're going to replace it with another beta 1. And that beta 1 is not going to hold oxygen the way it should. Does that make sense? All right? It's because of this setup here. You've got to have 2 betas and 2 alphas. But fetal hemoglobin is not conducive in an adult. It takes about 6 months for that transition to happen. When you're born, for your body to make hemoglobin F, which is fetal hemoglobin, into hemoglobin A, which is adult hemoglobin, it takes 6 months for your body to do that change. Because you can't keep that fetal hemoglobin in your body. It's going to keep the oxygen bound to your oxygen much tighter. You need to come off to go into the cell so you can, use it for energy and make it ATP. So in a person who's got thalassemia, they're missing some of those chains, and it's being replaced with certain other chains. And the hemoglobin is not going to function that well. All right? So erythrocytes are thin, delicate, deficient, and chains are defective. They get replaced. All right? And that's what's happening with this. Okay? They start breaking down. So there's many different types. All right? Not here to show you the different types. What you need to understand is the terminology. We have thalassemia major and thalassemia minor. And we got beta or alpha. you see the word major, that's one that they usually die in their 20s. Okay? If you have thalassemia minor, then they'll have mild effects. You could live to 120 and you're fine with that. No transfusions or anything. Okay? So their cells look like little targets. So they look like this. See how they look like little targets? You do a blood smear. That's how you can tell thalassemia. Okay? So the treatment for this, thalassemia minor, no, there's no treatment. It's just you're more like you're a carrier. Okay? Now what's important is that if you are a carrier and your husband or wife is a carrier, then there's a good chance you might have major. Like they have to do that. Thalassemia major, they're going to have many transfusions. The prognosis for minor, that's good. But the prognosis, like I said, for thalassemia major is that they usually die before 20 years old. Okay? Questions on that? All right. So there's different types over there that I kind of mentioned. We didn't talk about pernicious, but we'll get into that.